And so we've got 6 o'clock Central Time. I'd like to say welcome to everyone out there, and thanks for joining us for online office hours this evening. And tonight we're going to talk a little bit about the clinical practice guidelines and neck pain. And I'm really excited about this topic. My colleague and I, Mike Crow, we like to review the clinical practice guidelines and get the opportunity to actually join and update a chapter in the therapy ed textbook or the study guide, review and study guide. And so we always like to update the clinical practice guideline information for you all each year. So a little bit about myself here. I am Dr. Brad Tragord. I'm the chair and program director at UT Health in San Antonio, Texas. So I see a few friendly names on the Zoom land participant list there. So Nicole, I see you out there, and maybe a few others. So what do I like to do? I like to teach our musculoskeletal content here. My background and training is in orthopedic manual physical therapy. Got my DPT back from Army Baylor in 2007, and then did my doctorate in science is also my fellowship in manual therapy there in 2012. And I've been involved in entry-level education for the last several years, actually. So really enjoy doing that here in San Antonio. If you haven't been to the Riverwalk or the Alamo, I encourage you to find your way here at some point. I will go ahead and admit the last few people as they trickle in. So I apologize if I'm kind of looking off to the corner as I admit some more of our folks. But tonight, what are we going to do? We'll spend a little time discussing the clinical practice guidelines. And it's really important, I think, for all of us to realize that the clinical practice guidelines are updated evidence. And we all know that the National Board Exam is a textbook-based examination. But really, the practice guidelines use and integrate information over the last several years, a lot of which is in the textbooks, in which then you'll be tested on in the National Board Exam. And so we'll make sure to point those key areas out. And so I hope that tonight's session not only prepares you for the board exam, but also helps challenge your clinical thinking. Because the practice guidelines are outlined to help us look at the examination process, the subjective and our objective hands-on exam, our thinking or our evaluation, and also helps direct or help us prioritize our interventions going forward. So with that, we will talk about some subgroups, and so you're going to want to become familiar with the different subgroups that are outlined here and the components of the examination that fit into that. All right, so if you're not already familiar, you should be familiar with the big three, right? The musculoskeletal, our cardiopulmonary, and our neuromuscular or neurorehabilitation pieces of the pie. Don't forget, we have other smaller pieces, your non-systems and other systems, including lymphatics, as you prepare for the board exam. The board exam itself, you should be, again, familiar with how it's broken out through the content outline. We'll talk a lot about the examination, evaluation, and differential diagnosis. So, for example, when to refer patients with suspected fracture or those that might need surgical evaluations. And then, of course, those that, the various interventions that we encounter. So before we get going too much further, I'd like you to throw in the chat function when you plan to take the board exam yourself. I know a lot of us are probably looking at the July timeframe, but some may be looking into October or beyond. So I'd like to get a feel for the audience at this point. All right, yep, a lot of July folks. Already somebody looking in 2025. I like that. And yeah, several Octobers. So we've got a good spread tonight, but probably, yep, July. July is going to be the dominant figure. So right around the corner for you. Yes, musculoskeletal will take upwards of 27% of your board exam. So I would encourage you, if you're not familiar, this is a great section to focus in on. There's a breakdown for your reference. Again, I encourage you to look at the content outline on how to help you, with your studies and prepare for what portion of the exam is most important for you at this point. So before we review the clinical practice guidelines, let's look at some relevant anatomy and biomechanics of the cervical spine. So we got listed here is a image, or on the left, you see a lateral view of the cervical spine. You want to observe the lordotic curve and recall that the C1 or atlas and C2 axis make up the upper cervical spine. And then C3 through C7 vertebral bodies make up the lower cervical spine. Overall, the cervical spine is much more mobile than your thoracic or lumbar spine. The open and closed pack positions, and that's important to look at for any joint region, whether it's the neck or the low back or the hip. But think about the mid-range being more of your open packed or your resting position, and full extension, that closed pack position. On the right there, you'll see a typical vertebra, and that consists of your vertebral body along with the pedicles, lamina, which include the superior and inferior articular processes or facets, those transverse processes, and then the spinous process itself. And of course, in the cervical spine, we talk about the spinous process being bifid versus a unilateral or just a single process on the spinous process. This is a little bit more honed in view, but still a lateral view that helps you focus attention on the upper cervical spine. So C1, C2. That atlanto-occipital joint is a synovial articulation between the occiput and C1. It's also known as your yes joint. So a lot of our nodding, we'll call, or mention throughout the lecture tonight, comes from that articulation. The atlantoaxial joint is that non-synovial articulation between the dens, so that large C2 portion, and the anterior arch. All right, so then you have that C2, C1 articulation. That is known as your node joint, rotating back and forth. Much of our head rotation comes here, upwards of 50% of our neck or cervical rotation at C1, C2. That's important. Passive ligamentous support is potentially relevant. You can see all the ligamentous support around the upper cervical spine. This is really important when you look at a report of trauma to the spine or in certain systemic disease processes, and we'll talk more about that. But special orthopedic tests and measures, things like the sharp pursor, the alar ligament test, and the cervical distraction test are used as part of your complete objective exam, and we'll discuss more of those going forward tonight. These two figures are from the review and study guide. They help outline this intimate relationship between the spinal nerves and the cervical spine and the upper extremity. Remember, any symptoms in the arm or forearm or the hand, you really need to consider pathology in the neck, in the cervical spine as a possible differential. And so that really will often, if you have radiating pain, there's a whole subcategory or group that we'll talk about tonight to help you understand and differentiate. So neck pain, it's an important thing. Next to the low back and maybe a few of our other conditions, neck pain is really affecting upwards of 70% of our population, secondary to low back pain in terms of annual workman's compensation costs in the United States. There's some inconsistencies throughout the medical community concerning the pathoanatomic diagnosis and the classification or interventions that we use for the cervical spine. So the 2017 clinical practice guidelines, it does a nice job to provide us as clinicians a pathway to help with exam, evaluation, and our interventions. So they do this through this, this arrow out is kind of outlining the process that these clinical practice guidelines use, which is really logical, I think, for most of us, where there's medical screening, which we use as the baseline determination of the appropriateness of physical therapy. Do you need to refer? Do you need to treat and refer? Or are you able to keep the patient right there with you and treat? The clinical practice guideline recommends that we classify into subgroups, and we're going to talk a lot more about those subgroups tonight. It also then allows us or suggests that we determine the stage. Is this acute, subacute, or chronic? And we're going to want to consider other factors such as biopsychosocial elements and tissue irritability to help decide the treatment approach that we might want to start with. Ultimately, the CPG directs us towards evidence-based intervention strategies that we need to be familiar with. And they use the level A, B, C, and D level criteria. And we're going to focus a little bit more on the level A and B evidence. But in the clinic, your level C evidence is very valuable in many circumstances. This is a snapshot or a box 2-14 from your Therapy Ed Review and Study Guide. It provides a helpful summary of the clinical practice guidelines for neck pain, and we're going to first focus on differential diagnosis and these key recommendations here. So there are numerous anatomical structures in the cervical region that could be a source of your pain. That would include the facet joints, the vertebral bodies themselves, various muscles and ligaments, the nerves, neural structures, and their intervertebral discs. The source of neck symptoms may on occasion be something more serious, and therefore screening for clinical conditions such as cervical myelopathy, ligamentous instability, fracture, neoplasm, vascular insufficiency is really required early on in our process. Like I mentioned before, direct pathological causes of mechanical neck pain, it's really challenging. It's hard for us to identify in many cases. So we need to be really good at screening for red flags in our patients with neck pain to help determine the potential presence of serious pathology. Like I mentioned before, things like infection, cancer, potential cardiac involvement. Specifically, we should be alert for arterial insufficiency. We'll talk about vertebral basilar insufficiency, cervical ligamentous insufficiency, unexplained cranial nerve dysfunctions, and even fracture. All right, so tonight what I would like to do early on is get us tuned up with a few questions, and hopefully these are a little bit more related to medical screening. And so if you haven't joined us before, the way this will work is I'm gonna set a timer for you to read through this question, and after about 45 to 60 seconds, I'll go ahead and populate a poll, and you can select your answer. But then I'm going to cut us off right around 60 seconds, so then we can work through each of these since we have only limited amount of time. So I'm going to go off and let you, for the next 45 or 60 seconds, read through the question. I'll populate the poll, and you can input your answer. All right. Hopefully you can start to see the poll, but you still got plenty of time. All right, and maybe give you about 5 more seconds. So 5 or 10 more seconds, go ahead and get some answers in there. All right, last few folks. All right, and I'm going to end that poll. Let's talk about this before we share all the results from the poll. So what we have are a few key words highlighted here for you. So this question is asking about a patient that's 40 years old diving into a shallow pool of water. But then, it talks a little bit about range of motion. So we've got in the important thing I highlighted here is 40 degrees, because we're gonna see that how important that is in a moment. And then what diagnostic test or measure. And so you've got several options there listed. And the correct answer I have highlighted here that the majority of you all did get, I'll share those results, is obtain a CT scan. And so this question is really getting after something called the Canadian C-spine rules and your awareness of imaging and the appropriateness to be aware of that could be something that you find on the board exam. And so we're gonna work through this a little bit, but why? First, no additional tests and measures are needed. We have some concerning things in terms of a potential mechanism of injury with diving into a pool of water, but then a cluster of concerns with neck pain that's lingering and limited range of motion is going to lead us towards imaging here. So it's either probably CT scan or an MRI. Option C, no one selected that. Yep, those are probably more blood tests that are evaluating systemic diseases or infections. So good job overall. Now the question might be is why not an MRI? Well, you want to become familiar with the priority in evidence-based imaging recommendations. And so what you have here are the imaging and the Canadian C-spine rules that you should become familiar with, because the practice guidelines really suggest clinicians should be familiar with these. And again, to screen for and decide if radiographs might be important. And so going back to that case, we did have an individual that, although they weren't over 65 years old, you could have considered diving into a pool a dangerous mechanism, and that could have suggested that you get imaging right away. But even if you said, well, maybe that wasn't a high risk, but more of a moderate or lower risk factor, that coupled with the fact that the patient couldn't rotate their neck 60 degrees to both sides, one side was limited to 40, with their persistent pain, it would suggest that you would go ahead and get imaging. And CT scan is preferred. Probably radiographs would be considered along with that. MRI was a fine choice, and in some practice settings could be considered appropriate, but in terms of following the evidence, and the CT scan is being the optimal recommendation for this patient. All right, let's move on a little bit. The vertebral artery. Now we're just kind of moving on from that question, and we're moving on to other screening considerations that you should have as a physical therapist besides fracture. So the vertebral artery, which is a part of the vertebrobasilar system, as you know, passes through the transverse process of C6, and it supplies upwards of 20% of the blood supply to the brain. It courses next to those facet joints. You can see that along in the diagram on the left. And it really takes this 90-degree bend or turn, up at C1. And so that 90-degree bend in the posterior medial direction is thought to be susceptible to injury or damage from things like osteophytes, injury to the facet joints, any vascular changes like chronic diseases. Rotation and extension of as little as 20% have been shown to significantly decrease arterial blood flow, and therefore caution should be taken when examining the cervical spine. It's also helpful to note red flag conditions. So from a clinical standpoint, it's important to evaluate for neck trauma, cardiovascular risk, and ligamentous instability. In terms of these hallmark signs that you might want to become familiar with that are related to vertebral artery dysfunction, we have a box from the review and study guide listed, and you may have heard the mnemonic 5 Ds and 3 Ns, things like dizziness, diplopia, double vision, dysarthria, so difficulty speaking or finding words, dysphagia, difficulty swallowing, drop attacks, so kind of blacking out, or nystagmus, nausea, or numbness. And numbness really is focused around the mouth or the face a little bit in this case. So being familiar with with the red flag conditions of VBI is important when you talk about the cervical spine. It's not explicitly outlined in the clinical practice guideline, but it would be a good idea to review common and commonly used orthopedic tests and measures used to assess for upper cervical spine instability as well. And I would encourage you to review those pathologies that would warrant more exploration. Things like cervical myelopathy and ligamentous instability, those come up in terms of a safety and screening category on your board exam. And so I've listed the table from the review and study guide and also some red flag considerations for that. All right. Again, along the lines of safety, let's go in and test and measures. Let's go on to the next question. So here we go. 1 minute. Timer's on. All right, we're right at a minute here, so let's get some answers in there. Give you just a few more seconds. All right. Excellent job. I'm going to go ahead and end that poll. Yeah, the majority of you all have this one down. I'm excited for you. A lot of July test takers because this is common. But what do we need to think about here is the question's asking that you learn a patient has rheumatoid arthritis. What special test is most appropriate to determine upper cervical spine instability? So why rheumatoid arthritis? Well, there are a few conditions that you need to be familiar with that might lend themselves to upper cervical spine instability. Things like Down syndrome, um, Marfan syndrome, rheumatoid arthritis, of course, any traumatic injury like a motor vehicle accident. But even without that knowledge, you can see that the question's asking what test is used to test upper cervical spine instability. So the Sperling's test, often used for facet dysfunction. There are some reports that you could be used to help maybe load or pinch down on a nerve root. So maybe there's, some interest there. The quadrant test, certainly the same thing, much more of a facet than the Sperling's being more radiating pain and nerve root related. The quadrant test would be much more facet joint irritated, if you will. The craniocervical flexion test, this is an endurance test used with a blood pressure cuff. So we'll talk a little bit more about that. And so the sharp purser test is the correct answer. That's where you're going to stabilize the C2 segment and put an anterior to posterior force on the forehead, and things like looking or hearing for a clunk, or maybe the reduction of symptoms is a positive sharp purser test. So that's the correct answer. And again, you guys are tracking that. So excellent job. And a little less, I think, focused on serious pathology, but I think it's important that you consider this question in your differentials. So go ahead and take a look at this next one. Give you about a minute to look at this next test question. Maybe just 5 more seconds. So let's get some answers in there if you haven't had a chance to put an answer in. Excellent. I'm going to go ahead and end the poll. And I don't have to go over this one. You guys knocked this one out of the park. Excellent job. So what do we have here is, yes, you've got thoracic outlet syndrome. So not necessarily a serious pathology per se, necessarily, but something that early on in the screening process you want to be aware of. And I know we had a couple folks select vertebral artery obstruction or complex regional pain syndrome. Just to go over those briefly, the clinical presentation of vertebral artery occlusion varies with the area of ischemia, but you're going to be thinking about vertigo or dizziness, nausea, vomiting, head or neck pain would be common. Cervical myelopathy, no one selected that, but often that's bilateral symptoms. You'll have some upper motor neuron signs put into the question root, if you will. Complex regional pain syndrome is a chronic condition that is believed to be a result of dysfunction of the central or peripheral nervous systems, and it could include changes in the color or temperature of your skin. So you'd be thinking more along those lines, burning, pain, skin sensitivity, swelling, that type of thing. Yeah, but for this here, when you're looking at the thoracic outlet and associating that with hypertrophy of scalene muscles, you know that the key vasculature and the key components of the brachial plexus course right through there, through the outlet. So we don't need to spend any more time on that one. Good job. All right, so after considering your differential diagnoses and potential serious pathology, we need to move on. The clinical practice guidelines suggest looking at key examination factors, right? So there's your blow up from the review and study guide. Clinicians should be using validated self-report questionnaires to look at neck pain to help us identify patient baseline status and monitor changes relative to pain, function, and disability. So if you're not familiar with the Neck Disability Index, the patient-specific functional scale, or the global rating of change scale, I really encourage you to pull those up, review those individual questions, and consider integrating those to your clinical practice. Outcome tools are an important element in establishing our baselines for our patients. The clinical practice guidelines mention these and encourage their use. You should be familiar with like the NDI. It's not just used in the clinic, but a lot of our research, the minimal clinical important difference, it's based on the population that's studied, but it's generally 10 points if the patient has upper extremity symptoms or radiculopathy type things. So you can take a look at those and those questions there. The patient-specific functional scale, that's a scale that's a self-reported outcome measure of function where you have your patient identify 3 tasks. In some forms, you can list up to 5 different activities that they are having difficulty performing. And then there's an 11-point scale, right? 0 to 10. And then the MCID for this was typically reported as 2 or 3 points. That's similar to the numeric pain rating scale, 0 to 11 scale, so that's recommended. And then again, the GROC, the global rating of change, that has an MCID of 3, and that's important where scores of 4 and 5 are indicative of moderate changes, and 6 to 7 in the positive range would be large status changes. All right, so from the review and study guide here for you to look at and to kind of reference going forward is a description of these outcome measures and also outcome measurements that would be used for other tools will be listed in that same section. It's important to understand the risk factors associated with developing neck pain. So what might predispose you for neck pain? Moderate to high evidence suggests that the female sex and a prior history of neck pain are considered strong risk factors for a new onset. But then the lower level evidence suggests things like older age, high job demands, smoking history, low social support systems, and history of low back pain. So those would be things that you're looking out for in your subjective interview with your patients. The clinical course of neck pain is variable. I'm sure on your clinical rotations, you've seen this where there's a lot of unique traits to anyone with neck pain. But in acute neck trauma, that really, you should expect individuals to follow one of three trajectories: mild problems with rapid recovery, moderate problems with some incomplete recovery, and then severe problems with really limited recovery. And regardless of your outcome, it appears that recovery for most people happen within the first 6 to 12 weeks. So we're looking at prognosis and when things should improve, really, optimally. That's a great way to look at that. There could be considerable slowing though after the 12-week mark, and certainly if people are lingering with neck pain after 12 months, they're going to be in a very severe category. All right, to facilitate patient management, the authors recommend leveraging relevant examination findings to subgroup or to classify neck pain patients. So they acknowledge that there's 4 categories. They're not exhaustive. This is not the only way to look at neck pain. There's a lot of ways to help you diagnose or to stratify who might benefit from different interventions, but this is the current practice guideline suggestion. And instead of doing a full, really overly comprehensive examination, you're going to use sound clinical judgment and reasoning. You should use motion limitations, thoracic spine assessment, the presence of cervicogenic headache, any history of trauma, referred or radiating pain, as useful ways to subgroup your patients with low back pain. So listed here are the 4 classification subgroups. So neck pain with mobility deficit, movement coordination impairment, headache, and then radiating pain. And then listed under each of these boxes are key examination components or your expected findings on examination. And really the intent here is to subgroup individuals with neck pain with mobility deficits by including things like, do they have cervical active range of motion limitations? Making sure that you're doing the cervical flexion rotation test for upper cervical spine assessment, cervical and thoracic segmental mobility tests. Those that have neck pain with movement coordination impairments, you'll identify these individuals by including cranial cervical flexion and deep neck flexor muscle endurance tests. Those with headache, obviously, they typically complain of a headache. And those individuals, you would include things like range of motion, in particular, the cervical flexion rotation test, or looking at upper cervical segmental mobility testing. And then finally, the neck pain with radiating pain, things including that are more neurodynamic tests, Sperling's test, distraction tests, even the Valsalva maneuver or Valsalva test can be helpful. You can also take a few moments right now to think about just what your common body charts might look like or your symptom maps for these patients. So a symptom map for mobility category, but also your movement coordination impairment might look like someone on the far left. Your mobility deficits could be unilateral or bilateral, where your more movement coordination can be more widespread and maybe more commonly muscular involved. In the middle there, you have folks that are common symptom maps for headache category, which would include maybe non-continuous unilateral neck pain and associated headache referral. So headaches are precipitated or aggravated by neck movements. That would be a common subjective theme that you hear about. Maybe they're prolonged positioning, studying for the board exam, and they start to get a headache, and you start to associate that prolonged neck posture with a headache. Therefore, in the case of headaches, evaluating range of motion, again, especially the upper cervical spine, is key. And then on the far right, the common symptom map for neck pain with radiating pain is a classic radiculopathy following some sort of radiation down the arm. So just breaking this down a little bit further, we talk a lot about assessing range of motion and also evaluating segmental accessory motion. And that's recommended by the clinical practice guidelines. And so it's just good to pause and remind ourselves, as entry-level clinicians, we've got our physiologic range of motion, things like flexion and extension there on the lower left. But equally important is your ability to get your hands on and assess for restrictions or mobility deficits through your accessory assessment. And you're looking for not just, how does this move in terms of the quality? Is it hypomobile or hypermobile? But really, are you able to identify symptoms? Are you reproducing their pain at a particular segment as well? It's important to consider the deep neck flexor and cervical extensor endurance testing for those potentially placed in the coordination impairment group. I mean, this subgroup, you really got to think about doing a lot more, or they'll typically demonstrate a lot more muscular impairment. So the craniocervical flexion test is a test of neuromotor control. We're not going to go through it in depth right now, but the blood pressure cuff is listed in the lower right. That's where you would put that underneath the neck, and through a series of movements, you can see if the patient passes that two-stage test using the BP cuff. It's really the subject, is the patient's performing a little bit of a nodding action to test that with that BP cuff as a pressure biofeedback. The deep neck flexor endurance test is performed with the patient tucking their chin in and lifting off the table, and you as a therapist looking for certain faults or deficits, things like a hyperactive sternocleidomastoid, or maybe fatiguing and losing their form. There are normative values for this that you don't have to memorize, but it's important that that exists to give you confidence in using these types of special tests and measures. In the case of headaches, so headache, evaluating range of motion, especially upper cervical spine and segmental mobility, adding the cervical flexion rotation test is really important there. That's in the lower right corner where you fully flex the neck and you're really isolating the upper cervical spine. That's C1, C2. And then, also in the just looking at protraction and retraction and how that really could reproduce symptoms that are consistent with a cervicogenic headache. And finally, for patients reporting radiating pain, I mean, the addition of upper limb tension tests, the Sperling tests, and the distraction tests are all highly recommended tests. So really becoming familiar with these in preparation for your board exam is highly encouraged. Yep, I'll answer that question at the end, Amanda. I think it's a fantastic question in terms of looking at the CPG and what's it recommending, and so you will want to be familiar with both, no doubt. All right, so there's a couple tables in your review and study guide that do give a lot more information about upper limb tension testing. Remember, there's a sequence of events that go through these, and it's important for you as a clinician to monitor any neurological changes each step of the way as you go through the sequence. There's a lot of variations to these upper limb tension tests, and so as long as you're consistent in applying them in the clinic, and understanding the purpose of reproducing symptoms, they can be helpful for you. All right, now that we've discussed these major subgroup classifications, we're going to move on to interventions. So if you haven't got it now, I mean, the idea of these clinical practice guidelines are to help ensure that the patient belongs in your clinic and that you screen or rule down any serious pathology, that you use evidence-based outcome tools and your physical exam to create a good baseline. But from that information, you're quickly using your clinical reasoning to maybe subgroup to help you prioritize different intervention strategies. Because unfortunately, when you get neck pain, we can't point to a specific path, a specific intervention of choice at this point in time. All right, so here are the key intervention for neck pain with mobility deficits, and we're going to go through those in a little bit different view. So what I have here are listed are images, and these pictures represent the recommended intervention, but also the intervention strength of evidence per condition, and also look there's the stage, whether it's acute or subacute. So for example, for a mobility deficit of the neck, on the far left, there's actually level B evidence, strong evidence in the acute stage and the chronic stage to apply thoracic manual therapy or manipulation. In the subacute stage, it isn't really enough information at this point, and so it has a C level evidence. It doesn't mean you don't do it necessarily, but the strength of evidence is not there. All right, so generally speaking, for patients with acute neck pain with mobility deficits now, we should consider thoracic manipulation, a program of neck range of motion exercises, and scapulothoracic and upper extremity stretching and strengthening to enhance your overall effect. Now, for patients with subacute neck pain, we should really provide neck and shoulder girdle endurance exercises. At least that's the evidence that we have right now. That's level B evidence. Again, in the subacute stage. And then for patients with neck pain and that have a little bit more general fitness is recommendation for this more chronic, and also a multimodal approach is recommended for the chronic neck pain folks. So the combined use of manual therapy and exercise is recommended. You'll note trigger point dry needling is relatively new in terms of the evidence base for physical therapy, and so we're going to likely see that commented on more in the practice guidelines in the next rendition. Although there are some recent RCT level evidence that kind of suggests that the multimodal approach is adding this maybe to the multimodal approach is not necessarily of great benefit, but again, the verdict is still out. So that was, again, mobility deficits. Now we're going to look at the movement coordination impairment, and that includes a whiplash associated disorder. And so that WAD or whiplash associated disorder falls into this movement coordination subgroup. Same thing listed here, and the pictures are really representations of strategies or interventions that you want to become familiar with. The unique thing here, you're adding cervical collar and TENS in some subgroups. So there is some use or recommendations for these. So in the acute stage, we should provide education of the patient to return to normal, non-provocative or pre-accident activities as soon as possible. So again, you've screened already for fracture and ruled out serious pathology, and even in acute neck pain, we really need to be advocates to return to movement and return to prior function. Again, just to reassure yourself, the evidence suggests that after 6 weeks, maybe upwards of 12, your patients, the majority of them are going to be better. So we got to be confident and reassure our patients in most of the cases. So that's going to happen. It's also helpful to use a multimodal intervention approach that includes manual techniques plus exercise for patients expected to experience a moderate to slow progression or recovery. All right, so we're going to move on for this movement coordination and move towards the headache subgroup. We're going to list a little bit of that right here. Again, listed here are pictures that represent a variety of intervention strategies that you might need to look into and prioritize for your own clinical practice. But for those with acute neck pain, with headache, we should be providing supervised instruction and activity of mobility exercises. For a subacute, you're probably looking more at cervical and thoracic mobilizations. For patients with more chronic, you have a more robust strategy or multimodal strategy that looks at manipulation or mobilizations combined with shoulder girdle strengthening and endurance exercise. Again, this is the current recommendations that are A and B level, but there are other treatment options for that subgroup. All right, and then finally for the radiating pain category, this is where radiculopathy would fall into. We have a few recommendations here. Low-level laser and intermittent traction are kind of unique to this particular category. Patients with chronic neck pain that's radiating, we should be considering mechanical traction combined with other interventions such as stretching and strengthening. Across the board, we should be doing education and encouragement to continue occupational and exercise recommendations for chronic neck pain. All right, so again, those are all strategies with aligned level evidence recommendations for you. One thing with this particular group, radiating pain, and this is similar for your low back pain patients with radiating pain, you really need to go back and look at the centralization phenomenon and how that kind of equates to us as physical therapists in terms of our treatment strategies, but also prognosis. And so if you're not familiar, you've got a diagram on the left that the gray represents symptoms, things like pain or numbness that are distal in the hand. And then as you work your way from upper left to the upper right, and then to the middle figures, and then down to the very bottom lower right, you see that that gray area is progressively getting closer to the midline or the central portion of the body. And that centralization, if it persists, like if it continues to, the symptoms stay more proximal, and, they're moving physically away from the distal segments and going more proximal, that's a sign of centralization. And that's just really correlated or associated with a better recovery. And so whether it's repeated movements or traction or some sort of other mobilization strategy that you're doing, if you're seeing your patients or hearing them talk about their symptom map on their body moving from a more distal to more proximal area, that's considered a strong positive association with recovery. All right, and so what we've had a chance to go through tonight, like I mentioned, is this kind of 4-step approach that the guidelines suggest you use, but intermixed with all that is a lot of, I think, history and particular components that you might find on your board examination. And so the practice guidelines really provide the pathway for us to be really good examiners. It helps us think and reason, and ultimately helps guide some interventions based on the recent evidence. Medical screening is really our baseline determination for appropriateness of physical therapy. And as you're getting ready for the board exam, you've got to think the board exam is there for you to look at, are you safe to practice? So look at those screening strategies, the evidence-based strategies, and the common serious pathologies that are being potentially going to come into your clinic as focus areas to study. I think the CPG really does a good job of subgrouping for you to help you in your clinic endeavors. The components of the objective exam that you might find within each of those subgroups are high value areas that would be tested on the board exam, things like the special tests and measures, the range of motion parameters, and understanding upper versus lower cervical spine and how that can refer symptoms. And then ultimately, in terms of interventions, focusing in on the level A and B evidence, I mean, those are pretty enduring type evidence recommendations that you could then use and help prepare for the board examination. So what we'll do now is we've got a few more questions, and then we'll open it up for a few discussion points, if that's all right. So let's go ahead and move now to the next few questions that we have. I'll give you about a minute to read and answer this next test question. I'm launching the poll. I'll give you about 5 more seconds. If you can go ahead and get your answers put in there. And I'm going to go ahead and stop the poll there. Let's take a look and see how we do here. All right, so a few key pieces to this question, and this is a little specific for the information that we covered tonight, but you've got an individual with subacute neck pain. They fit into this movement coordination impairment category. And now really it's asking if they have whiplash associated disorder, what's the most appropriate test? Now, you could argue any or all of these are appropriate, but if you had to look at movement coordination impairment, how do you prioritize? I mean, that's really what the question's asking you. And I would say that we got a nice spread, but the vast majority of y'all, if I share the results here, yeah, you got the right answer. You're already tracking that, this is probably an endurance challenge that or problem that we need to focus in on. Now, again, this is not to say the other exam items are not important. So the Sperling's test, again, that's where you're probably placing the patient's neck in slight side bending and doing an axial load to close down facet joints, but ultimately to pinch a nerve, then to send radiating pain down the arm. And that would be most appropriate for someone that has neck pain with radiating pain. So good, no one selected A. B, cervical mobility testing, absolutely appropriate as a physical therapist, no doubt. However, mobility testing, what will be the result? Most commonly, you're going to find things like hypomobility or pain. You could find hypermobility, and that may help you in some circumstances, but probably the more important answer there is C, where cervical flexor muscle endurance testing is going to be looking at more your endurance or strength. And we highlighted that as a key component for the movement coordination impairments. Now, cervical flexion rotation test, we'll talk a little bit more about that, but that's also looking at range of motion to some degree. So B and D, both kind of looking at motion or mobility. And so when they're talking about a similar construct, might be reason to actually rule those out. All right. Next question. The clock is on. Okay, we're right at a minute, so I'm going to give you just a couple more seconds to get your answers in. All right, so I'm going to go ahead and end the poll. Let's talk about this one as well. We have a little bit better spread, or a little bit more spread here, and I get it, because this particular question, it probably isn't getting after anything specifically which we talked about tonight, and there's a little bit more interpretation from the question. So, and I think it's important that you look at the question as well in this case, because it says what element or elements from the patient interview make a diagnosis of cervical radiculopathy most likely. I mean, so reading between the lines here, we might want to look at what information comes from the patient interview. And there's several things here, but that could help you rule down maybe the positive upper limb tension test, for example. It could. But let's go through this first one. And A says associated referred pain to the upper extremity. Absolutely. Neck pain with associated referred pain to the upper extremity should get you thinking this could be cervical radiating neck pain. But cervical radiculopathy is a little bit more of a precise diagnosis than radiating pain. And so I think for some of us, this is a good point in time to remind ourselves referred pain might just be a source of symptoms that's felt distal or excuse me, not distal, but remote from the actual source of symptoms, right? So it's like when you put pressure on my facet joint and I feel it in my shoulder area or maybe behind my back on my scapula, that could be referred. But when we talk about radiculopathy or radicular pain, that really needs to follow a dermatomal pattern. And so C is probably the better choice in that case. And so we're asking symptoms that follow a dermatomal numbness or myotomal weakness pattern. That's probably the most important piece where they show you or describe to you that type of symptom map or signs, if you will. Acute onset of unilateral neck pain. What we don't know there with B is whether it's unilateral and just local or if it's indeed radiating. And radiculopathy would be falling into the more radiating category. And then the last one, D, like I mentioned, that's a little bit more of an objective test and measure. However, it's also by itself really more of a sensitive test. So when it's positive, it may not be as helpful to diagnose radiculopathy, but it's when it's clustered with things like a Sperling's test, maybe the positive distraction test, changes in range of motion that reproduce symptoms. That's when it becomes more helpful with a positive likelihood ratio to rule in. Otherwise, by itself, we use it more as a sensitive test to rule down. All right, hopefully that helps a few of you all. I think we've got maybe one or two more here. Gonna go ahead and start the clock. All right, go ahead and put your answers in here. We've just got maybe 5 or more seconds left. And I'm going to end the poll. I'm going to go ahead and share those results. Excellent job for the vast majority of you here. Yes, so mobilizing and stabilizing exercises, if it's hard to recall, this really is a little specific for the practice guideline. So this is a little bit specific to tonight's lecture, for example, but a lot of times you'll have to discern the best intervention. And in this case, you get high level evidence that cervical mobilizing and stabilizing exercises are the higher recommendation for acute cervical radiculopathy. So look at the level A and B evidence in your studies, and I think you'll be in really good shape going forward. Again, the other answers could be utilized to some degree in the clinic, and this really goes back to tonight and what's the most appropriate. All right, let's do another one. right. Go ahead and then stop that poll. And sharing the results. So I would say that the vast majority did great. They identified a few hidden words here. So we've got to decide radiculopathy, instability, thoracic outlet syndrome, or spontaneous pneumothorax. I do think it's worth talking through this question because you're going to need to reason through a lot of similar questions. So you have a vehicle accident, and although your imaging, if you know your Canadian C-spine rules, or just you can rely on the fact that you can trust that there's no fracture, I mean, that is the case. What else could happen with a motor vehicle accident? Well, you could have stretching of the ligaments, right? And so those particular modalities or imaging modalities may not be best to find soft tissue like ligamentous injuries. So the patient continues to have intermittent symptoms of dizziness, heaviness, headache, range of motion limitations. And so you've got to decide, is this radiculopathy or thoracic outlet syndrome potentially? Spontaneous pneumothorax, you could probably rule that one out by, you think somebody has shortness of breath, maybe an injury that occurred and then it finally manifests a few days later with shortness of breath. That would be that case. But what you have here, arm heaviness, that could be cervical radiculopathy. But with the radiculopathy, you probably don't have things like dizziness. Occasional headache doesn't really associate or go very well with radiculopathy either. Same for the thoracic outlet syndrome. Certainly you could have arm heaviness, limited range of motion of the neck, but much less so dizziness or headaches. And so for those reasons, upper cervical spine is the better answer, or the best answer. All right, last one. Let's all knock this one out of the park here. Give you about 45 seconds and we'll wrap up. I'm going to give you 5 more seconds. So last few people want to put their answers in. That'd be great. And the poll here. All right, let's talk about this one just real quick. You have the cervical flexion rotation test. And what we're being told is that it is normal. So now the value, right? The physical therapist determines that they have normal upper cervical spine rotation. So what is consistent with that? So remember, total range of motion for the cervical spine is around 90 degrees, right? 80 to 90, 85 to 90 degrees. So if the upper cervical spine, C1-2 rotation, makes up half of that, you're probably looking at about 45 degrees. So that is the best answer in this case, is 45 degrees. Now, that's careful reading these questions and what they're asking, right? I think that's one of the biggest things here is, which value is consistent with normal upper cervical spine mobility. You want to know your total range of motion, what's normal. And you can be off a few degrees here, because even those that mention 65 degrees, if that's half of your range of motion, that would be someone's neck that's turning 130 degrees, overall. And that's kind of far beyond what normal is considered. And 85, that's D, that's probably your normal range of motion for total cervical spine range. All right. So hopefully we hit on a few domains that might remind you of some things to study for in your last few weeks if you're the July testers. But for those that are taking the test in October or even next year, hopefully we kind of brought to light a few items for you all to discuss in your studies going forward. One thing Amanda mentioned earlier was this: does the clinical practice guidelines specify if cranial cervical flexor test, right? That's the one we use a BP cuff, or the flexor endurance test is more accurate? And I'd have to go back and look at that. But I will say the clinical practice guideline recommends looking and performing both of those. My suggestion would be is for a test to be familiar with both, and that the craniocervical exam is a little bit more of a motor control test. It uses the BP cuff and the patient to kind of go up to certain levels or millimeters of mercury and then off and then back up. And so that's kind of your control monitor for muscles, where the endurance test is literally a sustained hold with a stopwatch. And that's a little bit more just straight on endurance. You can also realize that both can help you get a baseline. And if you don't have access to a BP cuff that day, or if you just need to be more expedient about getting a metric or an outcome test done, that endurance test is probably, a more efficient way to get that information. All right. I know we've gone over our time a little bit. Let's just give you maybe 2 or 3 minutes. If there's any questions, you can chime in or you can chat away.
Hi, thank you for putting this on. I had a question about um question I think yeah, question 5. Yeah, question 5 when it was like the element from the patient interview. When you're going through like the patient interview, is that considering both the subjective interview and like the objective examination, or like would patient interview just be referring to like subjective information you get from the patient?
Yeah, I should have been clearer on that. And that's my fault, where I should have said subjective interview, subjective examination slash interview. And I mean, when you get a symptom map, right, the patient should be describing their symptoms, and I hopefully all of you all are writing or drawing this down on a body diagram. I mean, no one says that that's required, but that's one of the most powerful tools. But certainly you're asking your patients to, point to their symptoms or describe their symptoms to you. And if they're showing you a pattern that goes like this, down their arm along a C6 dermatome, that's pretty powerful. Do you see what I'm saying with that?
Yeah, definitely. Thank you.
Yeah, and so I apologize if the question route wasn't clear enough, but if that makes sense to you, that's exactly what we're getting after.
Yeah, cool. All right. Thank you. Appreciate
Right
it.
on. Well, I didn't see anyone chat away. So I'm going to say good night to everyone and thank you very much. I'll stick around for just a few minutes. If you do want to ask a question, I understand. So I'll stick around. But otherwise, um, good luck. Wish you success on your board exams here coming up in July and those in the future.